Well, welcome again, and let me start off with understanding of reproductive physiology as we go ahead. So this is an agenda. We'll talk about the agenda which my presentation will cover here, and there are one or two more which I have not put it. And we are also going to discuss something on gonadotropin, some basics on gonadotropins, because all of us use gonadotropins in our practice, and we should know those basic understanding of gonadotropins very well. And probably that way we'll take a break and do that up with all of you. Well, this is what is very well known to all of us, that it is a primordial follicle which grows further into primary, secondary oocyte, a tertiary oocyte, a preantral follicle, antral, early antral, late antral, pre-ovulatory follicle, and a corpus luteum. And this is the way the growth continues. All the primordial follicles will have oogonia, and these oocytes come from the yolk sac, and they come to the germinal ridge. When they come at a germinal ridge between about 7 to 8 weeks of the fetal life, the surrounding mesenchymal cells will surround those oogonia, and they are called, then that becomes a primordial follicle with a squamous epithelium covering those follicles, and that comes from the gonadal ridge. And with different mechanisms, probably an interplay of estrogen and androgen, or you can say an interplay of AMH and androgens in that female fetus will decide how the gonads will descend down in the ovary and how the uterus, the uterine cavity will form, how it will come ahead together. And that's why we commonly see Mullerian anomalies commonly in hyperandrogenic situations like polycystic ovaries. You will see polycystic ovaries with unicornuate uterus or bicornuate uterus or even with septate uterus very commonly. And this is because the whole physiology is that way. It is the androgens with the female fetus is exposed to decides how the descent of the gonad and the uterus will come together and form further. We commonly understand this as there is the initial phase till preantral follicle development is FSH independent. I hesitate to say that. It is never FSH independent. It is FSH dependent, but it is not FSH responsive. So if you don't have FSH at all, your primordials wouldn't go ahead. So it is not FSH responsive. You can't predict, I'll give this FSH and let the primordial kick off. You can't say that way. So no visible responsiveness is there, but it is definitely FSH dependent. And we don't know much about the earlier development. Neither it is of a great clinical relevance. Probably Dr. Lavanya's lecture will put a focus onto these things, how much we can make, as a clinician, we can make a difference to this earlier growth and push your primordial and all those follicles into the preantral and further FSH responsive status. So at 4th month of fetal life, ovaries will have about 6 to 7 million on oogonia will be there, and they'll be arrested in the diplotin state of meiotic prophase. And this continues, this arrest continues for the last oogonia, it may continue for 50 years, and at the age of maybe 45, 50, it will just ovulate. The resting primordial follicles continuously enter a growth phase, and by menarche, about 0.5 million remain. About 1,000 are lost every month, and the initial follicle development is there. Then there is an FSH-dependent progression in this growth till preantral follicle, and then the LH responsiveness will come as the follicle matures. So LH is basically responsible for maturation of a follicle. The primordial follicles, as you see, at birth, there's a cluster of primordial follicles there, and by 25 years, it has come down to maybe just 1/5 or 1/4, and there is a further decline. At the age of menopause, there are hardly any primordial follicles remain. And this is a natural fate. We really do not know the trajectory. We really don't know the determinants of the trajectory of the fate of the primordial follicles. Could there be an inflammatory insult, like somebody having an SLE, somebody having rheumatoid arthritis, somebody taking long-term antibiotics, or an injury or a surgery? Will that fasten this trajectory? We're really not aware about, or not many studies have been done, but we understand probably yes, there must be some pathophysiological things which may fasten this trajectory and deplete the lady of primordial follicles. That's what we understand from the oncofertility as well. All these primordial follicles are situated in the cortex, in just 0.1 or 0.3 millimeter of the cortex. And well, the cortex of the ovary hardly has any blood supply. The blood supply comes from the central medulla all the way to the periphery. So the primordial follicle is a pretty avascular structure. But it moves towards the medulla. The moment it moves towards the medulla, it is more near the capillaries. There will be more capillaries. And these capillaries will get the food supplies. It will get the hormones, it will get different ions, vitamins, or whatever, your amino acids, everything will come down there. And then that will set a biological clock, and the growth will be set in. And that growth is depicted by forming a primary oocyte, which is a cuboidal follicle, cuboidal than a squamous epithelium. And you can see in the picture, that's a cuboidal thing which is developing. The primordial is going a step further. So who goes ahead first? There's a typical hierarchy maintained. See, they are females, very strict in their behavior. So the one who comes first to the germinal ridge will develop first, or in the male fashion, will die first. The one who comes last, because the fate of the follicle is death, atresia. And the one who comes last will develop the last. So which follicle remains till the age of 40? The one which has arrived at the germinal ridge last will remain at the age of 40. So that follicle has gone through all the epigenetic insults in the life, and probably that follicle may not perform the best. But the earlier one, the younger ones, they have arrived early. That's why they are developing early. And that's kind of a biological clock which has been set in. I really don't know how they ever did such kind of a study to find out this biological clock. And basically what happens is once the things become cuboidal, they start developing FSH receptor. So they start growing near the capillaries, and then the gap junctions form. The gap junction is a very, very important thing. Gap junctions are nothing but tentacles of this granulosa cell going across the zona and touching the ulema. It's like they are the bridges which get the food from the capillaries and push it to the oocyte. The oocyte is the largest cell in the body, has to have the best of the cytoplasm and best of the nutrition in the cytoplasm. Because this oocyte is going to get ruptured, well, then it is in limbo for 5 days till it becomes a blastocyst and implant. For those 5 days, no blood is supplying there. So it has to have adequate amount of nutrition in that cytoplasm, not only to grow and divide, but to behave like a female, to repair the sperm also, and repair the sperm DNA fragmentation, etc., etc. So it needs highest amount of energy. So these gap junctions are literally going from the somatic cells deep into the ulema, and they keep supplying. And these gap junctions develop in response to FSH. So whenever the FSH goes up, the gap junctions tighten up. And these gap junctions not only tighten up between the granulosa and the ulema, also between the granulosa cells themselves. So there is a nice channel established of getting the food from the capillaries and pushing it to the oocyte. Secondary follicle then develops, which has multiple layers of granulosa cells. And this secondary follicle has moved to the medulla. So because the follicles are developing multiple layers of granulosa cells, it says push, 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 push to the medullary cells. And those medullary cells which are pushed now become theca cells. So you have a theca interna and a theca externa. The theca externa becomes a little more muscular because the follicle has to contract for the rupture. But while the theca interna is more, it's not only vascular, but it's also more hormonal dependent. Hormone generation takes place in that area. So preantral follicle has a avascular part and a vascular part during its course of development. The theca externa is highly vascular. It gets all the nutrition and the hormones to the theca, and then it goes all the way to the oocyte. But let me tell you, who decides, well, I want so many granulosa cells? Who else? The female herself. The oocyte decides, I want so many granulosa cells. Nobody else can. Okay? The nature starts then there, and that's what we see now. Okay. So the oocyte decides. The factors which decide this are BMP9, BMP15, and GDF9. Your growth determining factor, bone morphometric protein 9 and 15. So they determine whether granulosa cells should proliferate or she should not. And what do you think? They help proliferation? They say, no, don't proliferate. Typical female, always remember, oocyte will act like a typical, don't do this, don't do that. But then, it cannot have action all the way to the peripheral most granulosa cell in the theca cell. It says, well, the control of the oocyte is not reaching me. So let me develop some FSH receptors. Let me develop some LH receptors. And now the hormone cascade starts from the periphery, and that goes inside, and the follicle develops further. So the innermost cells will develop FSH LH receptors the last. They will develop when it becomes an antral follicle, maybe beyond 14 millimeter. But till then, it is the peripheral cells who are taking the FSH LH and doing all the jugularly inside. Now, why this BMP9 and all is important? The literature has found out if the follicular fluid is rich in BMP9, then it is the best follicle. It is a follicle, becomes pre-ovulatory first. It is a follicle which has maturation better and it has a better embryo quality. Today, BMP9 as an investigation is not available to us, but probably all you youngsters are going to practice for another 40 years. I'm sure in your lifetime, you will see a BMP9 or the follicular fluid or a serum level as an investigation to find out whether this follicle will do better. The science will progress. At present, we know the follicle which has the highest amount of BMP9 has the best vascularity as well on Doppler. So I'm sure this will evolve further. So there is something called continuous recruitment. The follicles just keep getting recruited. Imagine they don't get recruited. What will happen? Well, nobody will get menopause. They have to get recruited continuously. And why do they develop? Why do they get recruited? We don't know. That trajectory is not known to us. And the natural fate of any follicle, once it gets recruited, is what? Luteinization or atresia. It has to get atretic or it has to get luteinized. So there is something, GDF9 could be granulosa in proliferation, PMP15 promotes mitosis in the granulosa cell. And obviously, FSH is involved in these resting follicles. So it is FSH dependent, as I said, firstly, but not FSH responsive. How much time does it take? Primary to early antral follicle is about 6 to 8 months. Your early antral to pre-ovulatory time is about 3 months. And the rise in FSH in the luteofollicular transition decides the cohort size, amount of, that will decide how many follicles should develop further. And only the antral follicles, if they are there, they can have a second wave of generation can be there. There's some amount of antral follicle is there, and the luteal phase, again, they will start developing further. This time interval is again important. When they came out with endometrioma surgeries, initially what we understood, when you do an endometrioma surgery, the AMH will come down. The ovarian reserve will come down because you have done surgery, you have cautery, there's inflammation. Okay, all that will take the ovarian, the follicle count less. At the end of 6 months, the primordial follicles which are there, they would have grown to preantral and they would again start expressing AMH. See, there is AMH of 3. You do the surgery, down 6 months, AMH of 1.5. Okay, but the primordial follicle has now again grown to 6 months. So not 6 months, actually down 3 months it will be AMH of 1.5. Down 6 months, the primordial follicles have grown. They are now contributing to AMH, and again the AMH will come up. That's the way we understood. This was based on the physiological understanding of the growth pattern of 6 months from primordial follicles to the preantral follicles. But the systematic review has clearly stated that this is not true. Once you do a surgery, the anti-Mullerian hormone and ovarian reserve progressively comes down. It never gets up again unless you have a very good ovarian reserve right in the beginning and you're very young, because the young lady will secrete growth factors. And those growth factors are responsible for the preantral to manifest AMH expression, and that can happen only in that subpopulation. Otherwise, always remember, there is no self-correction. It will just on a detrimental go. Let's talk of androgens. Behind every successful oocyte, there is a male hormone there. Okay? So what is the role of androgens and FSH and how they start off the whole thing? There are some nice studies done on granulosa cell cultures, and what they did is they looked at the expression of the FSH receptor. Believe me, FSH receptor expression to be checked is very easy. FSH hormone to be checked is very less difficult because the very small increments are seen. So depending upon the receptor expression, they decide, well, the FSH will be acting in this. And they did cultures with estradiol and testosterone and dihydrotestosterone. And what they found, that FSH receptor expression increases in a culture which is rich of testosterone and dihydrotestosterone. And with increments in the doses, more and more FSH receptor form. And they also looked at expression of the aromatase enzyme or CYP19 enzyme. And they looked at that, and they said estrogen and testosterone together synergistically form expression of more aromatase enzyme. Dihydrotestosterone doesn't play a great role there. So androgens, this is the way androgens increase the sensitivity of the follicle to FSH. In your older women, we always give some androgens. Am I right there? I'm going to visit that up. So this is the basis of it. The androgens increase the FSH receptor expression, and hence they increase the sensitivity of the follicle to FSH action. DHEA is the main precursor of androstenedione and estradiol. The DHEA comes from circulation. It has got to the Theca cells, and it goes to the Theca cell, and DHEA gets converted further to androstenedione, testosterone, etc. And androstenedione will enter the granulosa cell and will get converted to estradiol. And that's why probably on this, Norbert Gleischer-based DHEA supplement, all the Kassan study and all those studies came up of DHEA supplement of older women. We'll talk about that in a moment. So this cytochrome P70 is the main enzyme to produce DHEA, which is abundant in Theca cell, and that is regulated again by LH. So LH decides how much DHEA should come to a particular follicle. And then some of the thecal androgens, because they are at the periphery, they will enter the circulation. So even in women, we will have testosterone and androstenedione detected in the circulation. So LH stimulates the thecal androgen. Androgen in the granulosa cells will increase FSH receptors, as we studied earlier. Androgen will also convert to estradiol and act by estrogen receptor beta to induce aromatase. So androgen, this is a vicious cycle. A small loop is developed there. The androgen, aromatase, estradiol, again with androgen, more aromatase. The whole loop is, an autocrine loop is developed in the cell itself. So androgens directly increase FSH receptor in granulosa cell, and testosterone directly can increase the mRNA FSH receptor. And that's probably the whole concept of giving your testosterone gels to your women to improvise on the FSH sensitivity. We'll also talk of that in a moment. So you have a primordial follicle pool, and that goes further to become cuboidal, etc. And primordial to preantral follicle is mainly by the local growth factors as well. So do primordial and resting follicles undergo apoptosis or atresia? Believe me, no. The primordial follicles do not undergo atresia. When they try to grow, they will go into atresia. Till the time they don't decide to grow, they are happily sitting there in the ovary, like a progenitor cell. So primordial follicles initiate growth and become atretic because they are trying to grow. Lee et al. Found that atresia-related gene expression is not seen till preantral follicles. So primordial follicles are like progenitor cells with no growth for a long time, resting and minimal metabolic needs they have. They all needs increase once the birth of the lady takes place. Till then, no need. That conveys primordial will age minimally. It is more subject of cumulative damage because of a natural aging process. And that's where I feel ovarian rejuvenation has a role to play. So can we awaken these primordial follicles because they are not aging anyway, and they can be made available at a certain age to become a pre-ovulatory follicle. So it's not an aging oocyte, but it's an aging ovarian environment which follicles are recruited and grow, and that is the spoiler. The environment is the spoiler. And that's where all your roles of your lifestyle, your yogas, your healthy diets, all that comes into play at that level. Because what environment you give the oocyte to grow will determine further. So all primordial follicles can make to a competent oocyte. Can we culture the primordial follicles? And there will be more oocyte pool. We are doing an ovarian tissue cryopreservation. We are doing oocyte vitrification, we're doing embryo vitrification, but can we culture primordial follicles? Take a tissue of the cortex, preserve it up, and culture the primordial follicles. That will be an endless source of follicles for that lady. Imagine everybody at 25 does a laparoscopy, takes a small cortex, preserves it. That's a huge source of follicles for the future. Technology is yet to arrive, but sure, we will be there soon. So primordial follicles in the 2 millimeter of thin cortical layer, as they grow, they reach the corticomedullary vascular junction. What makes them move away? And one of the things which makes them move away is something called hyposignaling. What is a hyposignaling? If the cells, all the cells in the body proliferate, am I right? So the liver cell is proliferating. Can the liver occupy the whole abdomen? No. So this is called hyposignaling. The organ and the cell structure, they decide who will grow and to what extent they will grow and how many will die. So the life and death continues in this organ, and a particular structure of that organ is maintained. So whenever you touch the ovary, when you drill the ovary, when you injure the ovary, you initiate a hyposignaling and put the primordial follicles into the medulla, and they grow further. So I don't know if you know Dr. Rajan from Kerala, who was a reproductive endocrinologist practicing long back. As I was a student, we used to follow, he had a textbook of endocrinology, and he would say, don't drill the ovary, just needle the ovary. Just needle the ovary, the follicles will grow. And that was the thing, that you're damaging the hyposignaling. Hyposignaling gets altered. The ovary feels, well, I have to grow now. I have to repair it up. And the follicles will start off growing. And that's why And this is also one of the methods of stimulating an ovary or getting more follicles there. AMH, the local factors like AMH, your transforming growth factors B, activin, all play a role in holding the pool of resting follicles. Out of them, only the AMH is inhibitory. Rest all are proliferative in nature. So can we preserve the primordial follicle pool that, as I was just talking to you? And these follicles will exhaust as they grow or otherwise preserved in dormant state for 50 years in humans. In POF or diminished ovarian reserve middle-aged women, if you can do a primordial follicle activation, that could be a very good therapy. And Dr. Lavanya will tell us more about these things. A certain amount of LH is needed, isn't it? A certain amount of LH is needed. And we have all learned that only if 1% of LH receptors are occupied, the follicle growth continues. And we always ask questions, how come? We see the LH is needed for the whole follicle to become good, mature, but how come only 1% of the LH receptor occupancy can do the job? So how do LH act? LH, they will give androgens, there will be growth of primordial to preantral follicles. LH requirement is very low, and androgen treatments in reproductive age women can be given. The whole basis of giving androgen treatment is this. So what should you give? Androgen or LH? In adult women with low androgens, because all the adult women will have beyond 35, the androgens will come down, and there will be reduction in antral follicle count is not due to low number of primordial follicles. As I told you, the primordial follicles are there. It is rather slowing the progression of the primordial follicles to preantral follicles because androgens are less in that particular ovary. So this is a famous paper by Robert Gleischer, and he says that low androgen concentrations are associated with diminished functional ovarian reserve, and androgen supplementation in women with low androgen concentration has been reported to lead to an increase in functional ovarian reserve. And the whole concept of DHEA, you know what it came from? It came from DHEA was used as an anti-aging therapy in US, okay, and to increase the libido basically. And they found out a lot of these women got pregnant, and that's how Norbert Gleischer thought and went ahead and they started doing studies on DHEA supplements in older women so as to improvise the pregnancy rate. All concept came that way. So the clinical application of these androgens in our patients of diminished ovarian reserve and advanced age women, that we will be giving androgens so that the follicles grow further, the primordial follicles get recruited more. What you find, there is an intrafollicular depletion of androgens in poor ovarian reserve patients. Younger women, this is very important, younger women convert DHEA to testosterone and androstenedione better. So older diminished ovarian reserve patients can go for direct testosterone supplements. So your lady is 39 and 40, you're giving DHEA, but she lacks the enzyme to convert the DHEA into testosterone, which will in turn stimulate the growth. So older the lady, it's better to give testosterone directly. Younger the lady with diminished ovarian reserve, well, you can give DHEA. Testosterone will augment early follicle by increasing IGF-1 in the follicle. And this is one investigation which I'm highly, highly recommending to all of you. Do an IGF-1 level in your patients of diminished ovarian reserve or old age women. You will have a subset of women who have low IGF levels. Growth hormone levels will be low. And if they have a low IGF levels, this is the lady who will get better with growth hormone supplements. Don't go give indiscriminate growth hormone as a policy. ये अच्छा करेंगे, ये और एक बार ये भी करेंगे, 15,000 बढ़ेगा, ये अच्छा होगा. Select a lady. What will happen if you give indiscriminate growth hormone? If you give indiscriminate growth hormone, IGF-1 level will go up. And with IGF-1 level going up, there is insulin resistance. So the embryo will face insulin resistance and you will face more miscarriages. The glucose utilization is hampered. So be very discriminatory in your giving growth hormone supplements. Two indications I find. One, IGF level low. Second, you have gone through one stimulation cycle and you have faced poor embryo quality. How would you improve this embryo quality? Well, growth hormone supplement may be able to help you out. Not in all, it's not a universal statement, but these are the only two evidence-based indications I can find. What is the benefit of a 20-day testosterone treatment for the oocyte which is going to develop over 3 months? So Nicholas Polizos has just completed a study called T-testosterone study, T-transport study. We should go through all the papers of Nicholas Polizos. We will put you all those papers. And they initially started publishing on how many days of androgens is required for the follicles to grow. And they kept questioning, Why, you know? When it came to testosterone supplement of diminished ovarian reserve patients, there were about, I think, 8 RCTs, and there were 12 meta-analysis. And they published a report, Nicholas Paul, saying that we need more RCTs and not meta-analysis. He said, don't meta-analyze, do RCTs. Obviously, RCTs were low. One reason, as a joke, which female wouldn't like to take some testosterone? The second reason, the true reason is, who will be in the control arm? How can you tell a lady who is that you're older, that's why your androgens are not performing well? I have one option to give you androgens to improve. Other option, don't take androgen, let's see. And who will go into that let's see compartment? So the control group is not there. That's why there are not many RCTs when it comes to testosterone. So these people started a T-transport trial where they're given 3 months of testosterone. Go through those papers. Beautiful. They have taken the testosterone level in the serum beyond the male levels. I don't know how it works, but it has not worked. His interim results, I've just heard him in one of the lectures saying the interim results are not at all encouraging, and probably this is not working. So testosterone supplements may not work. How will it work? Well, a few acne here and there, a few hair here and there. The lady will become a little stronger, she'll feel energetic. But when it comes to the oocyte, it may not work. So don't be, well, I'll give you androgels and I'll prescribe you testosterone. Hold on. DHEA, yes, you can experiment, because DHEA never accumulates in the body. It is excreted from all tissues. You don't do a serum DHEA level to check. Till Norbert Gleischer has done it. What Norbert Gleischer today says is, you give DHEA, but it also accumulates. After 2 months, check the DHEA level. If he has given a cutoff, which I'm unable to tell you now, I've forgotten that thing. Sorry for that. If it goes beyond that, it could be harmful. So in reproductive physiology, every hormone has a threshold, every hormone has a ceiling. So a certain amount of androgen is needed, but a certain amount of androgen is harmful. So, but testosterone will accumulate very fast, and the serum testosterone level goes up, the follicular genesis will be halted. So be very, very careful when you prescribe testosterone to somebody old enough who is trying to develop that one extra oocyte, and probably you are harming her more than helping her out. So androgens accelerate primordial follicles. Exogenous androgens in diminished ovarian reserve increase number of FSH-sensitive follicles. It may not hold true for every time, since androgens will also inhibit LH. Exogenous androgen supplement does not increase intrafollicular androgens. Underline that. Okay? So in my practice, no, we are not given testosterone. Spend more time with the husband, we say. Androgen priming. So the concept is not giving androgens. You prime the androgens, increase the intrafollicular androgens. How will you do that? Administer LH in your diminished ovarian reserve list. In the next class, when we do on 26th, we will talk to you about how to use LH in diminished ovarian reserve in old age women to prime, do an androgen priming of the oocytes to get better yield. And you can promote androgen synthesis in the follicle. And one drug which promotes androgen synthesis in the follicle is Letrozole. Give Letrozole. Simple. So, you want to do dual stimulation? Yes, you do it. How do you do it? Use follicular phase Letrozole and luteal phase stimulation with gonadotropins. Your follicular phase Letrozole will accumulate the androgens, and that androgens will increase the FSH sensitivity, and now you use stimulation in the luteal phase, and that will kick off very well. I love this paper. This is a beautiful paper by D. Ziegler et al. And this is about, he looked at the FSH and LH during follicular phase. It looked into a natural IVF cycle. This is a beautiful question, isn't it? When does the follicular phase truly start? We know when it ends. When there's an LH surge, the follicular phase ends. But when does it start? And we simply tell clients that you have short follicular phase, you have a long follicular phase, but we don't know when it starts. We only know when it ends. And what are the factors which fine-tune the LH surge? And let's understand this. So what is a true functional onset of a menstrual cycle? And we all start treatment on day 2 or day 3. Am I right there? The luteofollicular transition has taken place 3 days prior to the onset of menses. The FSH has already started growing. So by starting any stimulation on day 2 and day 3, you are telling, well, I'm going to asynchronize you. And then you ask questions. Are both asynchrony tha re? अरे हमने तो चालू किया वो synchrony. So we will have to pick up that luteal follicle and start our stimulation then. Have you ever attempted starting letrozole or clomiphene 3 days prior? Try it out. You'll be surprised. You'll be so happy. Your letrozole will work wonders. Okay, but you should be prepared to do scans at day 8, day 9. You may give even your triggers or whatever you want to give, and you will have proper growth. Asynchrony will not be there. Proper synchronous growth will be there. The basal FSH signal, which kicks off follicle recruitment, is only 2.5 MIU. Difficult to detect and can't be measured because FSH has a long half-life of beyond 36 hours. So you can't do sampling so often. So it's impractical to know when the FSH really went up and kick-started the follicular phase. LH surge is very easy to identify. We just do a dipstick, a urinary dipstick, and that will tell you. So FSH baseline is too small to detect. And LH surge, what it tells, your follicular phase has ended. And we highly depend then on the surrogate markers like follicle size and E2 to guess the follicular maturation. We say the follicle size is 18 millimeter on day 8, and we say, well, she must have started a follicular phase earlier. Or the follicle is 18 millimeter on day 16, we say, well, she has a long follicular phase. But we are not, these are all surrogate markers. We really don't know when the follicular phase ever started. Let's ask one more question. Why does corpus luteum secrete estrogen? I'm not checking where. Well, there are cells there, and they would secrete estrogen as well as progesterone. But when they did studies, I forgot the author, they gave progynoa until about 12-14 days. They developed the endometrium, and then they shifted onto progesterone and stopped progynoa. And on day 6 and day 7, they did endometrial biopsies. Those biopsies without estrogen, only on progesterone, were same as the biopsies where estrogen and progesterone are acting together. So there are luteal phase estrogen, what does it have to do with endometrium? The gene expression and the biopsy reports are the same. So progesterone alone can help implantation and maintain pregnancy. So what is the role of luteal, corpus luteum secreting estrogen? So the basal FSH going up, the basis of it is the E2 coming down. Suppose in the luteal phase, if you don't have estradiol, how will the basal FSH go up? It has to come down. So the E2 basically comes down as the corpus luteum becomes corpus albicans. Your E2 comes down, progesterone comes down, and E2 coming down stimulates the FSH to go up, and the cyclicity of the follicular luteal phase or the ovarian cycle is maintained. So menstrual bleeding is solely a result of progesterone withdrawal. If the luteal estrogen is there or not, does not make any difference. All of us prefer giving 4 or 6 milligram of progynoa, starting maybe 6 or 7 days prior in the luteal phase to synchronize the follicles. Do they not get menses? They all get menses, isn't it? So estrogen has nothing to do with menses. It is the progesterone withdrawal to do with menses. Estrogen drop is only, it's a God-gifted thing to maintain the FSH to go high and maintain the cyclicity of an ovarian cycle. So summing up, it appears that progesterone withdrawal is a primary factor triggering the menses, whereas it is a drop in the estrogen which is responsible for elevation of baseline FSH and continuing in the cycle later. I'll try to simplify this. Look at the ones on the red border. In these patients, in the luteal phase, it's written 3, 2, 1, -1. So -1 is 1 day prior to the menses. Your inhibin will drop. Your inhibin is secreted from the bigger follicle. As the follicle becomes, the corpus luteum becomes atretic, the inhibin will drop. As the inhibin drops, maybe -1 or -2 prior to the onset of menses, the FSH goes up. And FSH is already up by the time she comes to you on day 2, day 3 of the cycle. And look down, the luteofollicular transition has taken place. Your progesterone, estrogen are all going down, and that also corresponds to inhibin going down and FSH going up. Now, correct it. Supply them progynoa from day 26 and see what happens in the next diagram. Your estrogen has gone up, your inhibin has come down, but the FSH has not gone up. The FSH starts going up beyond day 3 when your progynoa stops. So that is the role of your late luteal estradiol supplementation. I think this is a wonder thing. And you feel very few people do it. There are universities owned in Spain and France, they do without progynoa, they don't do any cycle further. Like Lille University, Didier de Villiers University. In Lille University, they don't like to do any pickups on Saturday, Sundays. So everybody gets progynoa, and they do stimulation starts only from Monday to Friday. So all pickups come Monday to Friday. Okay, somebody will receive 1 day, somebody will receive 3 days, somebody will receive 10 days. On top of that, the doctor announces, well, I have to go to ASHRAE conference, everybody on Pro-Gynova then. Will it harm? No, it doesn't harm. It rather enriches. I'll come to that again. Okay, so that is the whole, and you go through the Spanish studies, who's this? Velasco Garcia. He's a south of France cycle runner. His favorite is cycle. He was a fertility sterility editor earlier. And this guy is now with IVI Rama, and he has published enough data on giving Pro-Gynova pre-treatment for every lady, irrespective of age, ovarian reserve, everybody, just to scheduling of the cycles so that they can get their Saturday, Sundays off. Reproductive medicine is beautiful. So estrogen in the late luteal phase synchronizes the follicle herd, and most important, LH goes up. Have you ever thought of this? Suppose you have a patient on day 2 of the cycle, and you have this fancy habit of doing FSH, LH, estrogen, progesterone for everybody, every visit. And you do this level, and your LH comes 0.1. And then you're in a dilemma. Can you start off the stimulation? Should you not? Just give them Pro-Gynova. Just give them Pro-Gynova 4 to 6 milligram for about 7-8 days. What will happen? The endometrium will grow. Will the FSH go? No. FSH will be kept low. LH will grow. Now you are accumulating LH. What are you accumulating LH? You are accumulating androgen substrate. Can you do this only for IVF, or can you do this for routine stimulation? Do it for routine stimulation, nothing wrong. The client comes on day 2, you have done your LH, if you say, or she has taken some OC pills, or she has taken Lupret depots, and she comes on day 2, you're just planning a COH cycle, give 5-6 days of Pro-Gynova, start off the stimulation on day 7. You still like day 2 of the menses, that day 6 with the FSH, with LH better than day 2 because the LH has accumulated. And endometrium, well, it doesn't make a difference because the studies have told us whether you give 20 days of Pro-Gynova or 10 days of Pro-Gynova, endometrium still implants. The endometrium is sensitive to Pro-Gynova. Endometrium is not specific to Pro-Gynova. 1,000 picogram of estrogen level can have a 6 millimeter thickness. A 500 picogram of estrogen can have 12 millimeter thickness. It's just sensitive, it's not specific. So you can do that. Post-COC pill treatment, the FSH rise is delayed. So generally we stop Pro-Gynova, we wait for 24 hours and start our stimulations. Because the first 24 hours, the FSH is pretty low, and you may require a longish stimulation later. But the washout period is just 24 hours. But when it comes to OC pills, because it is ethinyl estradiol use, which is much potent than estradiol valerate in suppressing the FSH level, you have to give a washout period. Some people give it 5 days, some people give it 7 days, everything is welcome. We'll just understand follicular waves. We understand there are different follicular waves, and let's go in further. So there are different waves of follicles, the follicular wave is nothing but the FSH level going up, and that will take the herd of follicles ahead. So one of the things is at the ovulation. At the ovulation, when the LH surge takes place, there is also a rise in FSH. And that rise in FSH is enough to start a follicular wave. I always used to wonder, me and Sharayu would debate, itna sa FSH se kya hota rahega? But when we read this particular paper of natural cycle IVF, only 2.5 MIU hike is needed. Well, then that is adequate. That must be there. So a small FSH spike, which is there with the LH going up, that is enough to start off one more wave. But those follicles are developing in the luteal phase. They're developing an LH-rich, progesterone-rich environment, so they don't have surge going up, and they become an anovulatory follicular wave. Or you could have an early follicular wave, which is a typical, which we'll try our best to synchronize, which is a luteal-follicular transition takes place and the follicles start growing then. But some women, especially the older women and women with poor ovarian reserve, will have mid or late luteal anovulatory wave, and they would have 3 waves. The younger population will have 2, the older population may have 3 waves. Now, again, this is not consistent. It's not like every old lady will have 3 waves. No. There would be older ladies having 2 waves as well. And there would be having a younger lady with 3 waves as well. That will happen. In reproductive endocrinology, nothing is absolute. It's always perspective, and cycle to cycle differences are there, and that's why it is more interesting. So I've tried my best to explain you these things. You have an ovulation going up, the LH surges, and there's a small spike in the FSH which you see. Look at the first diagram. You have 4 follicles, all AFC, synchronized, and that's a typical early follicular status you have. When you go to the mid-follicular or LH surge time, you have 1 dominant follicle, and the rest of the follicles are still small. 1 follicle has been selected. And go to the mid-luteal phase. See what has happened. That dominant follicle has now become corpus luteum, and a few more antral follicles have started coming up. So, in the luteal phase, you have more antral follicles. Why? Because through the follicular phase, the FSH has kept high, and this FSH has pushed few follicles further. And that's why you have it there. Secondly, it is the herd going up. Out of the herd, few will become atretic. So it's a mixture of a few new AFC, a few atretic, and the corpus luteum in the luteal phase. And typically you will say, or your art AFC tha, on let's say on 26th day, and she was going to get menses after 4 days, and I started her off with 300 IU-HMG or gonal-F or whatever. And when I saw on 550, only 2 follicles went up. That is possible. That means out of 8, 6 were atretic. They never responded to you. So when you start luteal stimulations in your patients, you have to be aware of that. You'll have to tell your client, well, I'm seeing a good follicular there, but there is a possibility my yield could be less. And this is one big counseling lacunae in our practice, that we don't inform our patient what is forward follicle output rate, and we don't inform our patient what is oocyte yield. And that there is an attrition of the follicle output rate, and oocyte yield is the biggest lacunae in our counseling. So see to it that you counsel this first. Then no client will say, well, I had 15 eggs and only 1 blastocyst. Well, that's normal, that's the way you are, that's nature, it's nothing to do with me. But that you should have counseled beforehand, and then the whole thing becomes much simpler. When it comes to follicles, the earlier follicles who are less than 4 millimeter will have only FSH receptors, less than 1% is LH receptor. Majority are FSH receptors. When it comes to about maybe 8 to 12 millimeter, about 50-50. 50% are LH and 50% are FSH receptors. And when it goes to maturation beyond 16 millimeter, all are LH receptors. There is no FSH, completely FSH devoid status that is. So the follicle highly depends upon the LH in the later part. Will it depend on the LH in the earlier part also? Let's understand that a little further. And these are our ultrasound demarcations. 2 to 6 is your antral follicle count. 7 to 9 is antral follicle count plus some atretic follicles. You know, a lady has taken 4 cycles of IUI with me, all 4 failed, and she goes to one of you. And you do the scan, he said, what he's saying, 4.5 AMH, I can see 10 AFC here. Well, that's because of so many controlled ovarian stimulation cycles she has gone through. And that has created a pool of atretic follicles there, and actually useful will be still less. So AFC and AMH will never correlate with each other, unless it is at the extreme. You can't have a 0.5 AMH having 20 follicles, and you can't have a 6 AMH having 2 follicles. At the extremes, it will coordinate. In between, there will be quite a mixture of antral follicle count and your AMH levels. When the follicle crosses 10 millimeter, you say the follicle is recruited. That means whatever drug you are given, it has crossed the FSH threshold enough to push the follicle further. It is developing the LH receptors. Now it is going to, it's recruited. Beyond 14 is a dominant follicle, and beyond 16 is pre-ovulatory. So your trigger is beyond 16. Beyond 14, you are happy, feeling happy. Wow, kuch ho raha hai. Beyond 10, well, you started off well. And 2 to 6 and 7 to 9 is telling you what doses you start and how you will protocolize your client. LH, I think this is one paper. I love this author, Antonio Lamacca, and I've tried my best to read all his papers. Very practical, very beautiful papers. You should read all his papers on PPOS. And this is one beautiful paper. I've just taken 1 or 2 slides of this paper. You should go through this whole paper. It's freely available on RVM online. I think, Sharayu, we should make a whole cluster of these papers and hand it over. That will be one good reading material for all of you. And more you read on that, you will enrich yourself continuously. So this is one paper. I'm quoting a few things from here. And certain LH is needed. And that is called LH threshold. What LH is needed for the follicle to grow. Certain LH will increase intrafollicular androgens and will inhibit growth, and that's called LH ceiling. So if your LH levels on day 2 are less than 1.2, you are having a low LH pool for your stimulation, and probably the follicle may not grow very, very well. You may require longer stimulations. Okay, now this cutoff of 1.2 is very variable. Like Richard Fleming said 1.2, Roy Homburg said 1, and there was one more author, he said 0.8. All those studies were done on long agonist protocols where they had to do an LH level before they started stimulation. LH ceiling, in turn, depends upon the follicle size. A smaller follicle will be affected at a smaller LH level. it will stop growing. At a larger follicle, even the follicle LH goes up, it will not get affected. Let me give you 2 examples. You have a patient of polycystic ovary who has an LH level of, let's say, 8. So she's not a hyper LH polycystic ovary. You put her onto clomiphene citrate. Put a clomiphene citrate to it, and hypothalamus will get inhibited, and it will secrete GnRH, and in turn the pituitary will secrete FSH as well as LH. So now this LH from 8 will become 14. The follicles are young, the follicles are just growing. This 14 LH is enough for few of the follicles to stop growing, or all the follicles to stop growing, and in spite of giving 100 milligrams of clomiphene, on day 12 and day 13, you have no growth. So this clomiphene resistance could be manifestation of the LH going up, causing a ceiling effect. What is the ceiling effect? LH produces so much of androgen that the aromatase expressed by the high of FSH of clomiphene cycle is not enough to convert those androgens into estradiol. So the follicle continues to maintain androgenic milieu, and that's what we say your LH ceiling has acted and follicle has stopped growth. But I'll give another example. And you have started a stimulation of IVF. The client comes to you on day 7. You do an LH level. Heck of it. Do an LH. No need actually. You do it. And you find the LH level to be 40. Oh God. Gaya ye case. Luteinized ho gaya. Believe me, nothing has happened. Because your follicles are beyond 14 and 16 millimeter. This 40 LH will not do anything to that. Just put your antagonist, go ahead. So a higher LH will be detrimental to larger follicle, much higher LH. Okay? Rather, it's our experience, myself and Sharayu's, that when you have such high LH in 20, 24, 40, in the stimulation, thumbs up, you are surely going to get follicles. Good follicles that too. Because there's good amount of androgen substrate and the follicles will be much, much better than somebody who maintains 0.5 LH through the cycle. Okay? So be aware about these ceiling things. So LH, I think this is a very important statement. LH deselects non-dominant follicles. The LH does go up, but it will not allow the smaller follicles to grow. So it will deselect the non-dominant, only one will grow better. LH rapid increase will block the granulosa cell mitosis, but it resumes oocyte meiosis. I told you, LH surge is end of follicular phase. What is follicular phase? Proliferative mitotic on the granulosa cell. So high LH will block that mitosis and will mature the follicle because the meiotic resumption will always be there. Cumulus undergoes luteinization and the growth will stop further. This is one very interesting concept. Spare luteinizing hormone receptors. You know, this is like how the orchestra, the God has really developed such a beautiful orchestra, I feel. So why only 1% or less than 1% receptors are enough to grow follicles? What is it? What does LH cause? LH gives androgen substrate, and LH acts through ERK1 and ERK2 pathways in the oocyte. And because of those pathways, it is anti-apoptotic. What is the lady going to do? The oocyte will going to die. So LH, which gives male hormones, doesn't allow her to die. It gives anti-apoptotic factor or proliferative factors. That is the use of LH. Now, what we mean by spare receptors is there is a chunk of receptors, only 1% is occupied by LH, the rest are empty. But the androgen released from that is enough a substrate to grow the follicle, and the ERK pathway stimulated is enough to cause anti-apoptotic effect. Then what are the rest doing? The rest are waiting to get more LH. Once more LH comes, all the rest spare follicles are occupied, and now they suddenly start a high secretion of progesterone, which is necessary for maintenance of pregnancy. So the concept of having less than 1% LH receptor still holds true. But still doesn't convince you, isn't it? That why such very less receptors, you give gonalef alone and the follicles grow, and here I break my awaj and break everything and say, please don't give gonalef alone, please give some HMG with it. So the follicles which are there, the receptor, the FSH receptor, this is such a cool stuff actually. And you know, the receptor has a G protein coupled receptor on top of that, that's a ligand, to which the FSH comes and sits on that and the action takes place. The G protein coupled receptors are heterodimers or dimers or tridimers. That means they have tentacles. So the two receptors are nearby, an LH receptor as well as FSH receptor. Theca और granulosa बैठे बाजू बाजू में बैठे neighbors है. LH तो आ नहीं रहा है. The LH receptor is all vacant. FSH comes there. It acts on the FSH receptor, but the in-between bridge also has a tentacle going to LH. So what it does, the FSH receptor, when FSH acts, it not only stimulates the FSH action down the follicle, it also stimulates the LH pathway. So that's why even less than 1% LH receptors occupied, your folliculogenesis continues. I hope I made you understand that. That is what this is showing, that, so there are the upper diagram tells you that there is a tentacle going to the LH receptor. So you have an FSH sensitive phase, all 100% FSH receptor, less than 1% LH receptor, still the growth continues. Androgen still comes there. I always used to wonder where the androgen will come from. And gonadotropin dependent phase, obviously the LH is always there. So the kind of receptor system they have, they help each other and the whole system and the orchestra continues. We all see Posidon 1. What is Posidon 1? That means you have a normal ovarian reserve patient is not giving a good number of eggs. Okay, and what does, if you label somebody having Posidon 1, can you label it before? No, it's a retrospective diagnosis once you go through the whole cycle. And then you say, what should you do for Posidon 1 to correct that she doesn't become a Posidon 1 again? One, use recombinant FSH. Second, add LH. Then why not add LH in the first? Because in Indian population, Posidon 1 is very common. 70-80% is Posidon 1. That's why I prefer giving GONAL-F and HMG together. This is the two-cell two-gonadotropin theory, which is talking about, I'm not going to go in details because this is something which you all learned in your NEET days, NEET, 12th standard. In the granulosa cell and Theca cell, it is understood the granulosa cell has FSH receptors and the Theca cell has LH receptors. The granulosa cell also has LH receptors. So initially, as the growth starts, the granulosa cell, the Theca cell LH receptor will get a small amount of LH, which will give androgen production. So LH will convert all your DHEA, everything to androstenedione. This androstenedione will go across into granulosa cell because the Theca cell lacks CYP19, that is your aromatase enzyme. So it goes to the granulosa cell and androstenedione gets converted to estradiol. And now this estradiol does two things. Number one, it manufactures more and more FSH receptors and it manufactures LH receptors onto the granulosa cell. So now, as the follicle goes ahead, the follicle has become more sensitive to LH because it has developed more LH receptors. Now, so that LH receptor assures a certain amount of raw material is continuously coming to this follicle. Because as the follicle is growing, the follicle secretes enough amount of estradiol and inhibin, which declines the FSH. So in the early follicular phase, the FSH levels could be between 6 to 9. In the late follicular phase, the FSH level between 3 to 5. With declining FSH in a follicle which does not have LH receptor, that has only FSH receptor, so that follicle gets only FSH, but the level is declining, so the follicle stops growing. The follicle doesn't have enough aromatase to convert whatever androgen it had to estradiol. So aromatase accumulates. This becomes an androgenic milieu for this follicle, and this becomes an atretic follicle. The follicle who develops the LH receptor first, okay, that is a follicle which is now able to get good amount of raw material, and whatever FSH is coming to that is enough to convert that raw material into estrogen. So it keeps its estrogen high. Estrogen goes high, more FSH receptors, so they selectively develop onto this follicle. Estrogen going high, more LH receptors, selectively onto this follicle. Estrogen going high, more induction of aromatase, so selectively in this follicle. So this follicle selectively becomes a dominant and grows further. So a certain amount of that LH could be detrimental for a smaller follicle, that will become atretic. Then who decides this? Why this particular follicle became dominant, why the neighboring follicle did not? The female itself, always remember, the female herself will decide. So the amount of BMP9, the GDF9, that decides which follicle. This is called oocyte dominatrix. All these studies were come from Epig and Marzuk. And you should go to the studies which are published by Epig and Marzuk, very old studies. And they had the biggest website those days called the Ovary. That was the biggest website, and they had huge amount of research done. And they talked about the GDF9, BMP9, how they are effective. And that's what in brief I'm telling you about two-cell two-gonadotropin theories. Sure. Okay, let's understand a bit on letrozole. I think this is the commonest ovulation-inducing agent we use in our practice. So what happens in a natural cycle? Natural cycle, progesterone gets converted to androgens, and then there's androgens to estradiol, which you just studied. What happens in a letrozole-stimulated cycle? You have an aromatase inhibition. Because of aromatase inhibition, androgens cannot get converted to estrogen. So androgens accumulate. There's a back pressure. Because androgens accumulate, the progesterone accumulates. And this progesterone then gets secreted into the periphery, the systemic circulation. That is accumulating in the theca cell next to the capillary, and your progesterone levels go up. And the androgens in the follicles also keep accumulating. So you will have a high luteal progesterone in a patient who has letrozole therapy. With letrozole therapy, there is a very low estradiol level maintained in the follicular phase. Because of a low estrogen, there will be high FSH, but high LH also. The LH suppose the patient comes to you on day 9, I'll do an LH level in a letrozole cycle, LH will be 10, 12. Okay, because it accumulates, because you have given letrozole. LH remains high in this letrozole cycle, and LH is high prior to HCG trigger. When Dr. Sharayu will take you a trigger lecture, she will tell you how this is differentiated. And LH in the luteal phase is also not suppressed. What suppresses the LH in the luteal phase? A supraphysiological high estrogen level. But there is no supraphysiologically high estrogen level in a letrozole cycle. So LH even in the luteal phase is very good, and obviously your progesterone in the luteal phase is good. So it is very physiological. The whole letrozole cycle is much, much physiological. But then you have various maneuvers. You keep giving 4 days letrozole to somebody, 7 days to somebody, 10 days to somebody, just because Dr. Goody told 8 days dena hai, isko dena hai, wo dena hai. But look at it. When you give less doses of letrozole, the letrozole wash out in 2 days. So day 6 ko khatam hua, day 9 tak wash out ho gaya. So day 9 onwards, your E2 will pick up. While the follicle is ready by day 11, so will your E2 levels be very high? Not much. It has just started picking up. Okay, or it could be still respectably high. Somebody who given 7 and 10 days of letrozole, your E2 will be less even on the day of trigger. And who will be sufferers? In whom this will happen? Patients with high PCOS, a high grade PCOS and high BMI. So if you want to give letrozole for 7 days and 9 days, give it for women who are very, very heavy and who have very bad polycystic ovaries. Don't make it a routine to give 7 and 10 days. And last time, Rashmi, I think I was proclaiming 7 days of letrozole therapy, but this is what I've understood after reading further, that you have to select your client who will go on a high dose of prolonged letrozole therapy and who will go on a shorter dose. So you will have low E2 at trigger in IUI or high E2 at trigger for an IUI cycle. That would happen, that would differ. We don't do E2 levels in IUI, so we don't make a difference. So when you have a letrozole and HMG, and we have 2 follicles, you have high E2. That will alter implantation, and more ectopic pregnancies are noted. When they have done studies with letrozole HMG versus clomiphene HMG, they have noticed more ectopic pregnancies with letrozole HMG cycles. Now, if you're maintaining a good LH level in the luteal phase, and if you're maintaining good progesterone in the luteal phase, should you support letrozole primed cycle with progesterone? Should you give progesterone as your luteal support? This is a big scientific conflict. So one of the papers says that luteal phase support with progesterone does not improve pregnancy rate in patients undergoing ovarian stimulation letrozole. 2022 publication. It says no. Live birth rate is 10.7% and 12.5% with or without luteal progesterone doesn't make a difference. Odds of clinical pregnancy also were no change at all. So they said that giving progesterone in a letrozole cycle is stupidity. Go physiological and it will support itself. But this is a beautiful paper. This is a review of an Amigos paper, which is on unexplained infertility, where they gave letrozole, clomiphene, and gonadotropins, and they did IUI cycles. And what they detected, that the mid-luteal progesterone levels in patients who received letrozole and clomiphene was much higher when they got pregnant compared to gonadotropins. See, in CC cycles, when the mid-luteal progesterone was less than 14.4 nanograms, and when it was less than 13 in letrozole cycle, they did not get pregnancies. So they said that you have to maintain a high progesterone level. If you go by this study, you should supplement progesterone to everybody if it is a letrozole cycle. I think the principle, Dr. Sharayu is going to again focus on that. If you're giving a trigger, give progesterone support. What about clomiphene? See what happens. This is your natural cycle. Your LH is low, FSH goes up in the early, comes down in the later. With the ovulation trigger, or it's not trigger, the LH surge, FSH also surges a bit. But what happens in clomiphene? The FSH goes up 50% beyond the basal level of that lady. But LH also goes up because hypothalamus secretes more GnRH, and GnRH from the pituitary will secrete FSH as well as LH. So clomiphene is a high LH state. And this is very important for us because I told you one sentence, LH deselects smaller follicles. So if you have a large number of follicles, the smaller ones will not grow. And only the big ones will keep growing because the LH will not allow the smaller follicles to grow. We use clomiphene very commonly with our very poor ovarian reserve patients. You know, they have gone through standardized stimulations, they're not yielded, just yielded one egg or no egg, something like that. Then I would prefer giving Gonal-F alone because Gonal-F alone is a very good stimulation. But who will give me LH? I use clomiphene to give me LH. It will decrease my cost of therapy. So I can give clomiphene 100 milligram a day for 10 days or so, and that clomiphene will take the LH up. Gonal-F alone is a good recombinant FSH. Both will act together and the follicle will still grow, but my cost of therapy will come down. So this is generally a second cycle or a third cycle wherein we are accumulating embryos, and when we are totally convinced that this particular lady has such a poor ovarian reserve that this is the only solution, and then we can do this way. Now there was this study which was published by Alinani, but I remember this study being presented in Rome Escheré way back, long back, and this won the first prize. What they did, they started a stimulation with HMG, and once the follicle was dominant, now they added clomiphene. So it was a reverse therapy. In the later 5 days, they added clomiphene. What did that clomiphene do? That clomiphene will go up and sit on the hypothalamus, will not allow the estrogen rise to act on the hypothalamus, and that acted like an antagonist. Okay, it did not allow premature luteinization to take place. So suppose you have patients whom you are taking for IUI, they are developing multiple follicles, you are suffering LH high, you can use this kind of a therapy as well. You can use clomiphene later rather than putting antagonists, because the moment you put antagonists, you'll have to increase your HMG also. The whole cost of the therapy goes up. But the success of IUI does not improve. Success of IUI is only 14%. Am I right? Mine is at least that much. People are claiming high, but mine is only 14%. Okay, so it is worth trying to cost effective by doing such a kind of regimen. But I would definitely urge all of you to try stair-step protocol. Like you give Letrozole or you HMG, and day 7, day 8, your things have not acted enough. Rather than increasing the doses of HMG, increasing the huge cost to this lady, and then going through an IUI where the pregnancy rate are not going to be beyond 14-15%, and if you are the best, not beyond 30%. Okay? Just use stair-step, just add clomiphene there. So we would add about 100 milligrams of clomiphene, 2.5 days, 100 in the morning, 100 in the night, 100 in the morning, 100 in the night, and 100 in the morning. Just 2.5 days of clomiphene, 50 or 100, whatever dose you want to use. You're all worried about endometrial side effects. Am I right there? But very few studies say that there is a thin endometrium on clomiphene. Quote me wrong, prove me wrong. Most of the studies who have compared clomiphene with others always said the clomiphene endometrium and the letrozole endometrium is the same. Okay? Only when they use clomiphene and HMG, that endometrium is thinner than letrozole and HMG, but that doesn't make a difference. And again, Dr. Sharayu will quote you studies where the endometrium is something not to be much bothered about. So I go by only one thing I kept seeing in every conference. If your lady says she gets scanty menses with clomiphene, then you stop clomiphene. If she doesn't complain of scanty menses, don't look at the endometrium. Just go ahead and continue your cycles. Yes. So these are not absolute things. In some women will have premature LH surge, and some women won't. And what we say, the premature LH surge or premature luteinization, you can have an LH going up, but the progesterone won't go up, and that wouldn't be harmful. Actually, there's a huge hype on premature LH surge, premature luteinization. That's why we're using antagonist cycles so often. I feel at some point of time we will stop using antagonists. I'll be quoting you studies of Messinis et al. On that. I'll talk to you about that. And in the yeah.
Sir, can you just elaborate? If you said if you give a trigger, always give progesterone support. Can you elaborate?
In her lecture, Dr. Sharayu is going to have 2-3 slides on this, just dedicated to this particular topic. Is it okay? Yeah, she'll continue. LH surge. I think, Nancy, I've taken 1 hour and 15 minutes. I'm going to stop here because I'll take one more shot at it after some time. I think we continue further. Huh? So I'll stop here. We are going to learn about LUF, LH surge, something on what is the endocrine of a stimulated cycle, etc. But we'll do it a little later. Huh?